Hello, and welcome to our third international webinar sponsored by AOPO, the American Society of Transplantation, American Society of Transplant Surgery, Canadian Society of Transplant, European Society of Transplant, International Society of Heart and Lung Transplant, NATCO, the Transplantation Society, and UNOS. We're very excited to present to you timely information about COVID-19. For those of you who've heard our prior webinars, you'll know that we've really benefited from the international experience in dealing with this pandemic. We've used current information to help guide muted as we confront the ever-changing world of COVID-19. Today's webinar is going to be focused on helping us prepare for a future where we consider getting back into transplantation in a world where COVID has not yet disappeared. We're very lucky to be joined today by a diverse group of speakers from around the globe, and I'm very excited to present to you this wonderful panel. A special thanks goes to the planning committee from all of these societies, without whose suggestions, help, and insights this would never be possible. So I'd like to turn the program over now to our first moderator, Erica DeMars, who's going to be talking with us about testing issues.
Good afternoon, everyone. Welcome to the webinar. I'll be your moderator, as mentioned, for the first part of our discussion this afternoon, which is making sense of the testing. For this session, we have two speakers. The first we will be hearing from is Dr. Marwan Mikhail Azar, who is an assistant professor of internal medicine and infectious diseases and is joining us from Yale University. He will share with us interpretation of RNA tests, viral specimen loads, and optimal specimens to obtain. Our second speaker is Dr. Howard Gable, who is a professor of pathology at Emory University in Atlanta. He will be discussing COVID serology testing. Please help me in welcoming them both. I will now hand over the microphone to Dr. Azar.
Thank you to the organizers for the opportunity to speak at this important town hall. Talking about making sense of COVID-19 testing, specific testing results. Next slide, please. I'll start off by discussing viral kinetics of SARS-CoV-2 because these are important in understanding the performance characteristics of PCR testing. In COVID-19, viral replication begins around 24 to 48 hours prior to symptom onset and peaks at days 3 to 5 after symptom onset, as you can see from this diagram. Following around 5 days, the virus begins to drop, especially when testing on upper respiratory specimens. Next, please. PCR testing is highly specific across multiple different assays, and this allows to distinguish COVID-19 from other coronaviruses, which are causes of the common cold. Next, please. Sensitivity is also high, but does vary according to several factors, which I will discuss here. Next. The first factor is severity of disease. It has been shown in several studies that patients presenting with severe COVID-19 illness tend to have higher median and mean viral loads on presentation as compared to patients with mild disease, and therefore clinical sensitivity of testing is likely to be higher in patients who are sicker or who have more severe disease. Next. Next, please. The other factor that affects clinical sensitivity is the specimen type. As you can see from this diagram, patients who have testing on endotracheal aspirates have on average higher viral loads than comparative testing on saliva. And so testing of lower respiratory tract specimens is likely to have greater yield and greater sensitivity. Next, please. Other factors that affect sensitivity of PCR testing include specimen quality, especially when collecting things like nasopharyngeal swab specimens and saliva, as well as assay type and the specific analytical sensitivity, otherwise known as collection of different assays. We do know that certain assays that are commercially available are more sensitive than others. Therefore, false negative PCR testing can happen if testing is done either too early, before the peak of viremia, too late, after the peak of viremia, which for the case of COVID-19 is after days 3 to 5, with poor specimen collection, or if less sensitive assays are used. Next slide, please. So let's talk about optimal specimens for testing. In general, upper respiratory tract specimens are the go-to specimens for testing because they're easier to collect. As you can see in the blue table on to the right, Hansen et al. In the newly published Infectious Disease Society of America COVID-19 diagnostic guidelines have shown the sensitivities retrieved from multiple different studies on a variety of upper respiratory tract specimens. As you can see, sensitivity tends to be higher when PCR testing is done on nasopharyngeal swab specimens at around 90%. In reviewing these studies, the IDSA guideline recommends NP swabs, anterior nasal swabs, and mid-turbinate swabs as the most sensitive specimens. Oropharyngeal specimens tend to be less sensitive, as you can see here at 56%, so they're not recommended on their own. Saliva is an interesting specimen and has a lot of potential. There are potential issues with collection of saliva that may impact sensitivity, but one study done here at Yale showed higher viral loads in saliva compared to nasopharyngeal swabs in 38 matched specimens from patients with COVID-19, showing that there is a potential for application of saliva moving forward. Lower respiratory tract specimens tend to be higher sensitivity, but the studies are biased by severity because patients who tend to produce sputum and have a BAL fluid tend to be sicker, potentially mechanically ventilated, and are more likely, as I mentioned in the previous slide, to have higher viral loads. In general, lower respiratory tract specimens should be collected if upper respiratory tract specimens are negative and the pretest probability for COVID-19 remains moderate to high. Next slide, please. So I'm going to touch upon a little bit about prolonged PCR positivity and specific considerations for transplants. Next, please. So PCR positivity may remain for many, many weeks after initial testing. As you can see on the graph to the right, it's a study of around 85 patients in whom testing was done initially at symptom onset, and then serial testing was done over time. And you can see that the majority of this group continues to have PCR positivity into day 21, and several patients are PCR positive even beyond that. So we also know that viral shedding may be longer based on very preliminary studies in patients who are solid organ transplant recipients. From one study by Zhu et al., they tested 10 patients who were recipients for kidney transplants who were positive for COVID, along with 10 matched family members who were also COVID-19 positive. They found that the mean days of PCR positivity was 28 for the kidney transplant recipients versus 12 days for the non-transplant recipients, suggesting that viral shedding may be longer in solid organ transplants. Next, please. However, the significance of prolonged PCR positivity is unclear, and positive PCRs weeks down the line after initial presentation do not necessarily indicate infectious virus that can lead to transmission or worsening with immunosuppression. As you can see from this paper, from this diagram to the right, from a paper by Wolfel et al. In Nature, they were only able to culture live virus on viral cultures within 8 days of symptom onset from 9 patients with mild COVID-19, despite the fact that positive PCRs remained beyond the 8-day period up to around day 14 in the study. So even though PCR positivity is prolonged, in this study, culturable virus was only possible within 8 days. Next slide. Thank you very much.
Thank you, Dr. Azar. We're now going to hand it over to Dr. Gable.
Thank you very much for the opportunity to speak to this group. And I'm going to be talking about making sense of the tests, particularly as they refer to serology. Next slide, please. So antibody testing for SARS-CoV-2, let's think about how it began. In the middle of March, the world was fully engulfed by the SARS-CoV-2 pandemic. And around the world, there was an outcry, a clamoring for antibody tests, not to diagnose the disease, but to diagnose if somebody had the disease. And in order to meet the demand, next please, on March 16th, the FDA issued a policy with very relaxed standards compared to what they normally do. It had the regulatory flexibility, which could lead to more rapid testing capacity in the US. And the idea was get as many tests out as possible in lots of different laboratories and lots of different settings, and let's collect data. Well, with that, next slide, the floodgates opened. And it's important for everybody to know that there are currently 160, and in fact, 170 different tests are available since I made this slide. What's also important to know next is out of these 160 tests, 148 of them have not been reviewed by the FDA. So only 12 tests have been reviewed, and they are under emergency use authorization. As of last Monday, the FDA changed its policy, recognizing that there are a lot of tests on the market that are less than perfect. In fact, some of them are pure out fraudulent. And the FDA has said they have 10 days now to submit the paperwork that will allow for the FDA to review. Up until now, almost all of the tests that are out there were reviewed by the companies that are providing the tests, and they were supposed to be doing their own validations. Next. There are two variations of the tests that are available for the most part. There is a point of care type of test, which is shown on the left side. That's called a lateral flow assay. And on the right side is a test that has higher throughput and higher sensitivity and probably specificity as well. And it's an enzyme-linked test. It could be using an enzyme. It could be using chemoluminescence. It could be using electrochemoluminescence. But what you have to know is these are different platforms. They have different specimen requirements. And even when they're the same specimen requirements, there's still differences. For example, if one is requiring blood, the blood might be taken from a finger stick. It might be taken from a vein. It might be serum. It might be plasma. And while all of these tests supposedly are using proteins and antigens from COVID-19, they're not necessarily the same antigens. Overall, the predominance is of a particular type. I'll get to that in a little while. But how do these tests perform? Let me give you some personal firsthand knowledge I have, especially with the lateral flow test, that pregnancy-like test you see on the left side. That's the same type of assay that's used that one can get over the counter for pregnancy tests. So I happened to personally see in a hospital that was vetting the test where they had 20 different results in this lateral flow assay. And of the 20, 14 were clearly positive, 3 were clearly negative, and 3 were ambiguous, where everybody in the room would say, what do you think? Is it positive? Is it negative? Now, the punchline is that all 20 came from exactly the same person, and it was one patient that was tested 20 times on the same assay by the same individual, so there was no variability there. That's quite worrisome. But let's make it a given that the test that you're using in your facility is 100% sensitive and as close to 100% specific as you can get. Let's go to the next slide. What information do you actually have? Next. In honesty, what you have is a yes or a no answer. It's more important to ask the question next, what information don't we have? And that information is numerous. Next, firstly, we don't have any idea of the antibody's strength or its titer. Next, we don't have stability. Is this antibody that is around for a week, a month, a year, 10 years, or a lifetime. Next, there's a lot of literature out now talking about subclass identification regarding different functions for subclasses of IgG and IgA. So for example, different subclasses have different effector functions, such as their ability to trigger FC receptor expressing cells, leading to either phagocytosis or antibody-dependent cell-mediated cytotoxicity. We don't know that yet. What else don't we know? Next, we don't know whether of the functional properties and the fine specificity. We don't know, next, whether the antibody fixes complement. Next, we don't know whether that antibody is neutralizing. I can tell you that one of the immunologists at Emory, Andy Nish, who developed our enzyme-linked immunoassay, which I believe is as sensitive and specific as the testing one can get and valid. Andy told me that at least some of these antibodies are neutralizing in vitro. So having been a scientist for the past 40 years, my take on that is for those of us who live in test tubes, I have some really good news. But the important part next that we don't know is the antibody protective? We don't know. We don't know that for a lot of different reasons. We haven't really tested that yet. And then next, what else we don't know? As I said, next, the tests that are being performed typically are using the spike protein as a target. And in particular, they are using the spike protein as shown on this slide, the one closest to the blue molecule. It's the component that is part of the receptor binding domain. It makes the most sense to use this as a target because this receptor binding domain is where the virus binds to ACE2 and is able to enter the cell. The idea being that if you develop antibodies to inhibit this, you are going to develop protective type of antibodies. But it's important to realize there isn't just one protein on SARS-CoV-2. Next. There are actually 29 total proteins. There are 4 structural proteins and there are several non-structural proteins. There are accessory proteins. Some of these have been mapped. We know what they're supposed to do. Others, we have no idea what they do yet. And while we would like to think that the antibodies that are generated are protective, we don't know that they aren't necessarily detrimental. For example, there are virus models, for example, dengue, where antibodies to dengue can result in antibody-dependent enhancement and make the disease even worse. And while we don't know that that's happening with SARS-CoV-2, we don't know that it isn't true. And it makes me think about what we've all come to realize during this past week, where we've heard about these children who are being hospitalized with Kawasaki-like syndrome. And at least from my readings, Kawasaki syndrome has an antibody component to it. At least one idea is that a virus can elicit antibodies that lead to cross-reactivity with those antigens expressed on blood vessels, potentially leading to this disease. I have no idea whether that's truly happening, but unless we begin investigating all of the different antibodies that can be generated and which ones are protective and which ones might not be, we're not going to have answers. So in summary, we had this theory that by developing antibody tests, we were going to be able to get solid answers. And in theory, we thought we'd be able to move forward with the information. And to end, I'm going to say that I want to take a quote that I always attributed to Yogi Berra and was heartbroken to find out it was from somebody else. Next. In theory, there's no difference between theory and practice. In practice, there is. Thank you.
Thank you, Dr. Gable. For time purposes, I do have a few minutes where I'd like to ask some questions that have been brought up. The first one, if a patient that is currently waiting for a transplant is COVID positive, but no longer symptomatic, at what time would it be recommended that they could get transplanted? Do you either of you have any thoughts to that?
I can comment on that. We've actually tried to come up with a protocol to address that. I think, the first thing I'll acknowledge is that we're, operating in a very almost data-free zone here. So a lot of this is based on little data that we have and sort of clinical judgment. But I think based on the overall pattern right now is moving towards a symptom-based strategy to sort of discontinue self-isolation. And so our hospital has moved toward a 14-day symptom-based strategy of self-quarantine, after which, if patients are clinically feeling better, one can discontinue self-isolation. So that would be the minimum period. But in our protocol, we chose to go closer to do 4 weeks before having sort of quote unquote clearing patients for transplantation, just because of the sort of theoretical possibility of ongoing active virus. But we are sort of reassured by this paper that I shared, which is that infectious virus in one study was not able to be cultured beyond 8 days. So for now, we're going with 4 weeks, but there's a good possibility it might be too conservative.
Thank you. I just have one other question. This is more for the post-transplant. So we know that COVID-19 symptoms can also mimic rejection in a lot of our patient population. If we test them for COVID and they're negative, and we do all the other serology and it is negative, should we continue after a few days to test again for COVID or not? What are your thoughts on that?
So in my opinion, even if you were looking for the virus or looking for the antibody, because we don't know what other antibody responses could occur, you might think that you have no COVID response, but in fact you do. And I think we need to get more and more information. And I didn't answer on the last slide, but on the last question, but the decision on what to do in a patient who's COVID negative and the donor who's also COVID negative, that's a center by center decision, and it depends on how aggressive or risk averse each center is, because I don't think that the donor recipient combination alone is necessarily enough for each center to move forward.
Okay. Thank you very much to both of you for speaking with us today.
Hello, everybody. It's my pleasure to introduce the next session. I'm Luciano Potena from the Heart Transplant Program in Bologna, and I represent ESOT as a president-elect. And it's my honor to introduce a very dense session with many speakers. I would very briefly like to introduce each of them. We would first hear some lessons from Wuhan, from Professor Zhu from Tongji Medical College. Then we have Dr. Klassen from UNOS. Then we have Dr. Dominguez Gil from the National Transplant Organization in Spain, Dr. Trelevan from the McMaster University from Canada, Dr. Baker from University of Chicago, Dr. Friedman from Orlando, and Dr. Kathleen Murphy from the University of Pennsylvania, and then finally Dr. Paolo Grossi from University in Varese, Italy. So it's my pleasure to introduce and to give the word to Professor Zhu from the Tongji Medical College.
Thanks for having me. I'm glad to share our experience of returning to transplantation after epidemic of COVID-19 in Wuhan. Next, please. Okay. As you know, the city of Wuhan was locked down on January 23rd, and our last kidney transplant was performed 3 days before. Then after, the transplant activities was completely suspended until epidemic had been well controlled in the whole city, which means no new cases was reported for 2 weeks. And then after a lockdown of 76 days long, the city reopened its border on April 8th. And then on the same day, we performed liver transplantation under level 3 protection, as the hospital asked, even though the testing for coronavirus were negative for both donor and recipient. And then after that, with a very strict screening of SARS-CoV-2 PCR and antibody testing for all the people related to transplantation, including for donors, recipients, surgeons, nurses, and even cleaners, etc. We restart transplantation very carefully and gradually. And in fact, our hospital had paid for all the health workers to test PCR and antibodies before everyone came back to work. So then in the rest days in April, we have accomplished 5 liver transplantation and 12 kidney transplantation, which were close to the transplantation numbers in the same period in 2019. And next, please. And at this unusual time, it's very important to screen for donor and recipients. And as to the screening for donors, every potential donor must be tested negative for both nasal swab nucleic acid and IgM and IgG antibodies. Then, after 1 to 3 days observation, the time is spending on the donor situation. Nucleic acid testing and antibody testing will be re-examined to ensure negative before donation. And the samples will be sent to our hospital and be tested in our Department of Laboratory Medicine. And as to the recipient's screening, 2 times checking are also needed in accordance to our hospital's current policy. First, the recipient and his or her companion must test negative for PCR, for antibodies, and test the CT in the clinic. And then recipient will be admitted to the isolation ward in a single room with family member together. And then after a stay for 3 days, which was initial 7 days actually in the first 2 weeks right after reopening, the patient and the companion will be re-examined for PCR and antibodies. And then when the results are negative, they will be transferred then to the general ward, and then transplantation can be performed in regular operation room as usual. But if donation is urgent, in other words, the potential recipient has to be transplanted within observational time, then the surgery has to be done in the isolation operation room under level 3 protection. Next, please. Next, please. In a quick summary, at this moment, all the donors, recipients, and the medical workers must be screened for SARS-CoV-2, and both donor and the recipient should have negative PCR and antibodies for at least 1 time. And transplantation is required to be done under level 3 protection if the recipient is still within 3 days observation time. Finally, as you can see from the figure that our transplant activities actually had been impacted significantly due to the epidemic. I think our present restrictions will not be eased until the global pandemic is brought under control. So I hope it will end soon. Thank you very much.
Would like to introduce Dr. Klassen from UNOS. So please, Dr. Klassen.
And what I would like to do is present the current UNOS data in terms of the numbers of transplants and donors across the United States. Can I have the next slide, please? The geographic regions that I'm going to use in this brief analysis are different from the usual UNOS regions that have been used in the past for organ allocation. And these are more akin to census tracts in the United States, but I just want to point out that they are different. I think they're a little more appropriate for this sort of discussion. The next slide. This shows the number of deceased donors recovered by week in the United States. And what you can see is that on leading up to the pandemic, there were about 270 deceased donors recovered across the United States per week. In mid-March, this started to decline very rapidly, and by the end of the month reached a nadir of about 150. Over the subsequent weeks, things looked like they had stabilized and were starting to pick up, and I had hoped to be able to show that we were heading back toward normal, but that has not quite been the case. And so I think numbers in the past week or so have waned a little bit. So I think we still are steady, perhaps getting better, but it's a little premature to say that. I think we can point out geographically on the right side of the screen that in the United States, the Northeast probably is not a surprise, has been hit the hardest. And there's been somewhat surprisingly, perhaps not as big an impact in the Northwest, but it has been seen across the United States entirely. Next. This shows the number of deceased donor transplants by week and by organ type. The blue line on the left is the number of kidney transplants, and like the number of donors, that had decreased. These decreased significantly starting in early March, and decreased from numbers of about 370 or so per week down to about 200, and then again look to be starting to recover, but then in the past week or so have trailed off a little bit again. So it's again a little early to declare that we're emerging from the pandemic numbers that we had seen earlier in March. We'll have to wait and see. Again, the Northeast has been hit the hardest, and the numbers in the Northeast do remain quite low. Next, please. This shows the number of living donor transplants by week and also by geography. And what you can see here is that there was a very, very rapid decrease in the number of living donor transplants. Essentially, all living donor transplant programs in the United States really took a pause in their activity. And the numbers went from about 140 living donor transplants per week down to about 10 at the nadir. It does look like kidney transplants at least have started to increase, and I think we hear that programs are starting to be transplanting selected living donor cases as we go forward. Geographically, the decreases we're seeing all across the country, not just in the areas initially hit hardest, the Northeast and the Northwest, but really everywhere across the country. The Northeast still remains very low. There are small numbers of transplants being done, living donor transplants, in other parts of the country. We expect that this will gradually improve as transplant centers begin to open up and resume transplanting living donors. Next slide. This slide shows the number of waitlist additions and patient inactivations by week, actually. So the blue bars on the right show the number of COVID-related inactivations of specific patients across the United States. You can see as the pandemic rolled out, a number of programs inactivated substantial numbers of their patients on the waiting list. This is for all patients, but it's primarily reflecting kidney transplant waiting list numbers. You can see a week or so ago there was a spike on the label April 19th. That turns out to have been from a single very large transplant program that inactivated its entire list with the goal of then selectively reactivating. So that's a bit of an anomaly. The green line shows the number of new waitlist registrations by week. And you can see that has, starting in the beginning of March, steadily declined and continues to do so. How this will play out over time remains to be seen. Presumably this relates to the inability of patients seeking transplantation to access transplant clinic and evaluations for listing. I suspect this may ripple through the transplant activity for some period of time. However, there may be a backlog of patients needing to be waitlisted, and so this may rebound. But at the moment, this has not increased yet. Next slide, please. And I think this is the last slide that I want to show today, and this shows the number of deceased donor discards by organ type and by week. It's most important probably as a metric in kidney transplantation. And what you can see is that starting in March, the number of discards, which had been running about 20%, which has been the historical number, unfortunately, for the recent years, it increased almost to 30% by the end of March, but then subsequently has come back down. And so organ utilization in the context of kidney transplantation has improved and is back to what we have been seeing historically over the last year or so. It's less of an issue for heart, lung, and liver transplantation. And you can see the data there. I think that's my last slide. So thank you very much.
Hello, should I start?
Yes, please. I was muted. Sorry. Beatrice, please go ahead.
Thank you. Hello, everybody, and thanks for the opportunity of sharing the experience in Spain, one of the countries that has been most affected by the COVID-19 outbreak. Next slide. If we want to scale up our transplant programs, we believe we need very clear safety standards to start, and this slide summarizes what we are currently doing. Next. In the case of deceased organ donors, and the same would apply to live organ donors, we would not proceed with organ donation in confirmed cases of COVID-19. For cured cases, we require a minimum of 21 days after the resolution of symptoms and with 2 negative microbiological tests. The rest of potential donors, we assess whether there is a risk exposure or not. An epidemiological risk is defined as having lived or having visited an affected area or having been in close contact with a confirmed case within the previous 21 days. Of course, at present, all our potential donors have epidemiological risk. We then assess the clinical situation of the potential donor. If there are symptoms consistent with COVID-19, donation would not proceed even with no screening or with a negative screening. In case there are no symptoms consistent with COVID-19, would screen for SARS-CoV-2. If positive or inconclusive, donation would not proceed. Next. We have set the safety period of 21 days to exclude outliers in terms of incubation period, and screening is performed only with PCR. We don't accept antibodies. PCR test of a sample of the respiratory tract. The ideal sample, which is required in case of lung donation or donation of small bowel, is a bronchoalveolar lavage, followed by a bronchial aspirate, and followed as a third option by an oral and nasopharyngeal swab. And samples need to be obtained within 24 hours prior to organ recovery. Next. In the site of transplantation, we screen for SARS-CoV-2 with a PCR in an oral nasopharyngeal swab that needs to be taken prior to transplantation. If positive, the patient would be temporarily excluded from the waiting list. We don't have national recommendation of CT scan, but some of our transplant teams are requiring a thoracic CT scan prior to transplantation. Next. And in order to avoid the interfacility transmission of SARS-CoV-2, we are promoting the recovery of organs by local recovery teams. Next slide. The second important issue in order to scale up our programs is to gain evidence in order to refine our guidance. We are undertaking a national data collection on recipients of solid organs and hematopoietic stem cells who have developed COVID-19. We have information already on 802 cases. And important data is that 15% of these infections have been acquired in the hospital, 85% have been community acquired, and we have no single suspected case of donor-derived COVID-19. Most of the infections have been acquired long after transplantation, but we have had 2% of cases who have acquired the infection in the immediate post-transplant period, and this occurred at the very beginning of the outbreak. Of the 802 patients that we have collected in this data collection, we have follow-up information available on 665. 185 patients have died. This means that the case fatality ratio in the patient population ranges between 23 and 28%, depending on whether we use in the denominator the entire case series or just those patients with complete follow-up. And this mortality is higher than the one described in the general population in Spain, which is 11%. Next slide. And finally, to scale up, we also need to understand what has happened with the program during the outbreak. In the graph, you have the daily average number of transplants in blue and donors in orange at 7 days intervals in 2020 in Spain. You can see how, following the declaration of the national state of alarm, the donation and transplantation activity dramatically decreased by 80 to 85%. So we have gone from 7 to 1 donor a day, and from 16 to 3 transplants a day. Now, in order to scale up, we try to revert what has happened during the outbreak. The centers have been left the decision to undertake donation and transplantation depending on the availability of ICU, the epidemiological situation, COVID-19 free pathways, and situation of their patients on the waiting list. Donation has been basically activated in ideal DVD donors in the worst weeks of the epidemic. Now we're moving into ideal controlled DCD donors and expanded criteria donors, and the latest programs to be activated will be intensive care to facilitate organ donation and uncontrolled DCD. On the transplantation side, at the worst moments, we have been working with emergencies and critically ill patients, difficult to transplant patients, and now we're moving into the elective patients on the waiting list who are relatively easy with unexpected short post-transplant hospital stay. You take a look back to the graph, you can see that the 2 weeks, the last 2 weeks show a certain improvement. Given that our program is a good thermometer of what happens in the hospital, we're seeing some light at the end of the tunnel, not only for our patients on the waiting list, but for the country as a whole. Thank you.
Thank you very much, Beatrice. We can move on to the next speaker, Dr. Trelevan from the McMaster University in Canada.
Thank you, everyone. Thanks to the AST and the Town Hall Conference organizers for the chance to describe our approach in Canada to the COVID situation. And on behalf of my colleagues in Ontario, I'm happy to describe this plan. I'm fortunate in Ontario to work with my colleagues, Dr. Atul Kumar and Deepali Kumar, who have helped along with the other transplant program directors to develop this phase-up plan. Next slide, please. Ontario is Canada's most populated province, and about a third usually of donation and transplant activity for the country occurs here. And in mid-March, as you can see here in the graph, the transplant programs in Ontario were seeing increased COVID activity, and we decided to pause most organ transplant activity. This was in response to the uncertainty and the unfolding situation in Europe, described with the last speaker, and also in New York. All of the Ontario transplant program directors met and agreed to unanimously limit transplant activity only to those high status liver, heart, and lung recipients. And we also decided to pause activity for most kidney transplant, but limited this to continuing transplant activity for medically urgent or for those whose CPRA is 99 or above. So in developing this plan, we met daily to help monitor the pause, and the 20 or so program directors formed an incident management system, a COVID management system, and we had representation from our OPO, Trillium Gift of Life Network, senior leadership, and we had continued input from our donation leadership and our critical care leadership in the province. So between March 15th and April 6th, donation referrals in Ontario were drastically reduced by almost 60%. But by April 6th, it looked like in the community, as we were all becoming amateur epidemiologists, that the number of new cases and hospital admissions were starting to stabilize to a varying degree across the province. Centers like Toronto were still busy, and smaller centers outside were less busy. So we started to plan to more normal transplant volumes together as quickly as possible in case things continued to improve. We felt that if we waited, that we would risk losing further organs, and that we would also simultaneously extend our shared wait list time for anyone that was waiting for transplants over this period. Next slide. Our phase-up plan had 3 important components, and we used this to draft a living document that is now used and updated daily with changes and circulated by email. We developed the plan to phase up transplant activity on a backbone of agreed-upon clinical principles, some of which have been illustrated by speakers today and in other town halls such as this one. These principles that you're all familiar with, I think, include consideration of careful coordination with provincial and local hospital planning committees, strict recipient selection based on demographic criteria that will be reliably producing good outcomes, and those recipients that will be minimizing their use of other hospital resources. We wanted to coordinate our recovery teams in the province to minimize travel and to try and optimize local retrieval. And we also needed to ensure availability of PPE for all team members, which was no small feat. We wanted to continue to use a donor screening tool that we've been using since the pandemic that has 3 parts to it. There's a review of the institutional exposure risk, there's a review of patient contact and symptom histories for potential donors, and finally we use a PCR on both NPS and endotracheal aspirate samples with CT imaging done additionally for lung donors. We developed a plan for rapid turnaround SARS-CoV-2 PCR testing for recipients when they were admitted to hospital and ensured this was working in all our transplant centers. And then finally, we contacted all the potential transplant candidates for advanced screening to let them know what we were planning, and we developed a special consent script that outlined the additional nosocomial and community risks of contracting the virus as a result of resuming transplant activity during this time. We reasoned, though, that safe deceased donor transplant could proceed if we had agreement that hospital conditions were improving with regards to the community effect of the virus, and that there was availability of the essential resources both for treating COVID and for transplanting patients. So we developed a staging system with 4 color-coded phases, with red being our current conditions back in March when things seemed uncertain and the number of new COVID cases seemed to be increasing. We proposed then to move into the next stage, which would be orange, where conditions were stabilizing and that there was a predictable rate of new hospital and ICU admissions with significant transplant hospital capacity. At one point, our hospital was down to only 60% of usual activity. The next phase was planned, is now still being planned, is for yellow, where conditions are improving with a decreasing rate of hospitalization and ICU admissions for COVID, with at least sufficient transplant hospital capacity. And then finally, we're planning to move ultimately to green, where you would be resuming near normal transplant hospital activity. The plan is for each region to determine this individually and to examine this weekly. For each phase, we agreed upon clinical criteria for each adult and pediatric organ transplant group and circulated this. After getting broad agreement on each stage, we would focus on refining agreements specifically for next phases. So in this first phase, the orange phase, most programs have moved but have still limited transplant activity. So for example, in kidney, for the most part, to use old terms, it's mostly SCD only without ECD or DCD. For liver, we're just using standard NDD donors with some DCD donors for selected donors who are under 50 and with very limited living donor liver activity. For heart, it would be looking at normal NDD donors, but this was always going to be tied to local cardiovascular ICU utilization. And for lung now in phase orange, we're considering status 2 and 3 recipients for usual NDD donors only. Next slide, please. So most Ontario programs now are currently in the limited activity phase of orange for kidney, kidney pancreas, lung, and liver, with the heart now being in both yellow and even green phases of activity. So for example, for kidney transplant, we're now planning to move to the next phase in yellow to reintroduce DCD donors to try and identify those potential ECD recipients on our list who are most healthy, and to plan for limited increases in living donor kidney transplant activity. And then finally, for the green phase for kidney, we would plan on reintroducing DCD, ECD, and removing limitations on the ECD list. So we've learned a few lessons from our experience so far. For one, it took much longer to speed up than to slow down, and this is because of the multiple levels of integration with planning in our local hospital surgical services. There's a huge backlog, as you all know, of cancer and other crucial surgeries. We've had this plan in place, though, before other surgical restart plans were complete, and we had to do a lot of communication and even negotiation to have this accepted. And our senior leadership team and communication team was crucial in helping to get the initial acceptance of our proposed plan not to miss any potential donors. One of our original intentions was to capitalize on the differences in our regions to make use of the organs wherever possible and to route them directly where they could be safely used, for example, in regions that were more spared of the outbreak. Several centers, though, have already moved in and out of orange into red, back to orange, into yellow, because of local hospital and regional dialysis unit outbreaks. And I think that continuing consideration of outbreaks in dialysis units and long-term care homes linked to transplant center hospitals are likely to remain areas of concern and will need to be flexible. Finally, we plan to monitor the effect of our plan and, like others, are capturing information on COVID cases both in the dialysis and transplant populations. And there's a two-stage data capturing process that we have with a very quick, relatively small set of information gathered on new cases on a weekly basis, and then that's co-joined with a larger CHR national research project to capture more in-depth information on transplant patients. We also plan on participating in projects that will look at deaths on the wait list and a modeling project that will look at the effect of the pandemic on increasing estimated wait times for deceased donor organs over this time. So thank you for inviting me to describe this experience in Ontario.
Thank you very much. We can move on to the next speaker. We are a little bit late with our time, so I would encourage the speakers to be as much in time as possible. So please, Dr. Baker.
So thank you to the organizers for allowing me to present University of Chicago's approach to surgical prioritization in a global pandemic. Historically, we've certainly been guided by simple allocation principles and schemes, which are based on well-established ethical principles. Next slide, please. In the face of this global pandemic, however, we suddenly recognize that no single principle is sufficient to incorporate all morally relevant considerations. Next slide. In response to this, the surgeons at University of Chicago, led by Dr. Prashant, developed and published a scoring system to ethically and efficiently manage resource scarcity and provider risk during the COVID-19 pandemic. Next slide, please. The scoring system was based on the recognition that decisions to proceed with operative treatment in the setting of all phases of the COVID pandemic required incorporation of factors previously really not considered by surgeons, including resource limitations, risk to the healthcare team, and COVID-19 specific perioperative risk. It was recognized that three categories of factors were associated with poorer outcomes, increased COVID-19 risk to providers, and/or increased resource utilization. These included procedure, disease, and patient-specific sources. Next slide, please. A higher score for each factor in the procedural score was found to be associated with poorer outcomes, increased risk to providers, and/or increased hospital resource utilization. And these are outlined clearly here. The total scores you see can range anywhere from 7 to 35, but you should remember that in almost all cases, transplant usually is at a baseline greater than 30. Next slide, please. Higher scores for each factor related to the disease score indicates less harm to the patient if non-operative treatment is pursued and/or surgical treatment is delayed. Again, the total score range can be anywhere from 10 to 30, but remember the transplant scores will certainly range by organ type based on the assumptions of organ quality, availability, and alternative treatments. Next slide, please. And finally, higher scores for each factor in the patient score is certainly associated with a poorer outcome, increased risk to providers, and increased resource utilization. These scores, again, range anywhere from 8 to 40, and in transplant cases with all organs, usually are on the higher end, greater than 35. Next slide. So the procedure, the disease, and the patient scores cumulatively equal the total MENT procedural score. Transplant at baseline is generally higher than most other elective surgeries. The beauty of this system is that score threshold or surgical justification can be adjusted in real time based on local resources and conditions and the condition of COVID-19 pandemic and its recovery, and can be shifted dynamically towards higher scores, which allow more surgical justification during the recovery phase. Next slide, please. Certainly the strengths of this score are in its transparency and definitely in its dynamic flexibility based on current resources and conditions. It also importantly offloads some of the emotional and ethical workload, which certainly have been demonstrated to impact us significantly as healthcare providers during this pandemic. The weaknesses, however, cannot be overlooked and include that the factor scores may not be statistically proportionate within groups, and this certainly applies most dramatically to our transplant populations. And there can certainly be inaccurate and disproportionate weighting of factors, which is inevitable. Next slide, please. And finally, we as transplant physicians must also consider in an organ-specific fashion the donor organ quality and risk of exposure, the donor team and recipient team exposure, and I think we've all learned a lot about our thresholds for travel and for allowing local teams to procure, the likelihood of another donor becoming available in a timely fashion, alternative treatment options and exposure risk, as have already been discussed, for example, in hemodialysis units, and we must consider the consequent mortality risk if we choose not to transplant during this COVID pandemic. I'll leave you with that, and thank you so much for the opportunity to present.
Thank you very much. We can move on to the next speaker, Dr. Friedman from the Advent Health Orlando Transplant Institute. So please, Dr. Friedman.
Thank you. My name is Barry Friedman. I'm the Executive Director, Nurse Director for the Transplant Programs at Advent Health Transplant Institute. For those of you that know me, I function both from a military background and civilian background. So for today's talk, when patients return to clinic and phlebotomy, we dubbed this Operation Task Force in the post-surge COVID-19. And this was a response team that was activated to relaunch the Transplant Institute safely. And this went in alignment with our hospital reopening as well. I'd like to thank the previous speakers and previous talks because it certainly guided us with the information and intelligence that we needed to know to operate our center here in Florida. When transplant was deemed life-saving, we opted to continue our transplant program. And basically, starting in on March 17th, we began our operation to decide how we were going to function as a transplant center. As like most centers, we paused our living donor program. And as new policies came out from the government, relaxed HIPAA, CMS guidelines, CDC guidelines, deeming that transplant was life-saving, we created our specific criteria, just like my colleagues have spoken prior to me. In addition, we developed a team approach. For the first 4 weeks, we had twice weekly meetings with our medical and surgical leaders and key nursing, transplant, and from the hospital, our chief medical officer and infection prevention to help guide us with our institution, since we were a primary caregiver for the serious COVID-19 patients, and we're providing high-end care such as ECMO. So we needed to know what was happening within our institution. During this time period, the month of March, month of April, we each did 19 transplants, about 4 hearts, 1 to 3 lungs, 11 kidneys each month, a kidney, pancreas, and 2 livers. So the only thing that slowed down was our transplants, was our living donors. We created strategic initiatives. So basically, we wanted to ensure we could resume care, maintain financial resilience. How do we strengthen our workforce in a safe manner for both the patient and our providers? Our providers, we were very concerned, would contract COVID-19. We wanted to keep them safe as well. How could we accelerate IT and digital care for our patients and our caregivers? And how do we get that message across? Next slide. Our executive task force, we continued. You can see from a hospital perspective, we were involved in meetings both at the hospital and the ambulatory care side. Our physicians were very involved from a leadership perspective. We ensured our marketing team was ensuring our consumer was hearing information with the premises of ensuring that the support of safety, our supplies for the ensuring that our caregivers were safe, our patients were safe, and our workers were safe. But how do we maintain financing and then also testing for COVID-19? Next slide. So what was the new normal for post-COVID surge? We attributed that May 6th, next slide, per our governor, was going to be our beginning of our entry date, even though we started even back on March 17th to decide what our reentry would look like. What is the new normal? Post-COVID, our patients are trying to be scheduled, ensuring schedule flow. Do we do in-office versus telemedicine? So we've taught our schedulers partnered with our providers who deserves a telemedicine versus an office visit. And then we had to rethink our lab draws. Should the lab draw be done in the office prior to the visit versus lab draw during the visit? Our goal is to have no waiting. We would love to get rid of our exam rooms. That was something pre-COVID, but we'd like to go from car to the exam room to back to the car. We also reopened any elective surgeries, as most programs were chronic and end-stage organ failure, so our elective surgeries and procedure testing started this past week with full implementation this week. New normal will require a phased approach of staffing requirements. Many of our staff are still working from home, and we've learned a lot. And I think as a senior member of the team, gaining trust that your employees can work from home as well as in the hospital when necessary. Next slide. Pre-appointment screening. All patients will be pre-screened via phone. We have also contracted a new software called Freesia. This will help with screening questions prior to the office appointment. It's an app that can be used on the patient's phone all the way to the patient when they arrive here at the hospital. They stay in their car, and the Freesia application will tell them when to come to the clinic. They don't register anymore at our clinic. They'll register on the phone. Their co-pays can be handled on the phone. They come directly to the clinic room. They'll have all of their post-testing pre-examination during that time period, and then any discharge training would be done in that room as well, including any labs. Patients upon entry are being screened appropriately. We're offering hand sanitizer and a mask prior to entry. We're also doing temperature screening and the required CDC screening. Next slide. We also wanted to ensure our employees are being tested as well, masking and temperature monitoring. We're currently under an engagement, and it goes without saying that it's been very challenging. We want to test every employee during this time frame using a sputum monitoring. We are checking our temperature upon entry into our building. Providers and team members above a temperature of 100 will follow the pre-registration process for COVID testing. All providers and team members will be masked while in practice, regardless of patients present or not. And all administrative employees are also being screened and masked prior to entering the administrative areas in our building. Next slide. Personal protective equipment. We do provide face masks to all team members. Initially, it was weekly. We would give a mask. Now we're giving a surgical mask every day. We ask that the employee leave with that mask, and upon re-entry of the building, have their mask on in the morning, and then a new mask is given to them. We also have other types of PPE, such as gown, goggles, face shields, N95 masks, N100s are also available to those staff doing interventional procedures or seeing patients within our outpatient area potentially in our infusion procedure center. Next slide. We also want to ensure that we're practicing disinfection. We've worked with our environmental services focus, our environmental services. Each employee, though, is also being taught through guidelines to do comprehensive disinfection of the exam rooms after each patient, disinfection of waiting areas, front desks, and check-ins. That includes going around wiping down door handles, etc. Disinfection of other patient areas that patients may have touched. And at the end of the morning and end of every day, we disinfect and document with the manager on duty. Next slide. FREESIA, in summary, to provide a safe and modified environment for patients and team members. It's a virtual registration check-in with consents and collection of money. It offers COVID screening with documentation. There's a dashboard to monitor the registration and patient arrival, and it's interactive bidirectional texting with the patient. Next slide. Here's our reopening checklist. It's not the complete list, but this is something that's filled out weekly by one of our management within the transplant program. Next slide. And these are signs now that we have in all of our clinics. Stay 6 feet apart. Signs, hold the phone for check-in. There's nothing more important to us than our patients. We're providing extra cleaning. We have the 6 feet, please stand here waiting in line. And then in our waiting areas, if there are patients in there, we do distance by 6 feet. Next slide. That's all I have. If you have any questions, feel free to call or email me. Thank you.
Thank you very much for your very comprehensive talk. Now we can move to Dr. Murphy from the University of Pennsylvania. Please, Dr. Murphy, you can start your presentation.
Thank you. Hi, everyone, and thank you for this opportunity to speak today. I'm going to be talking about criteria to remove patients from quarantine after they've recovered from COVID-19 and some of what we're thinking about from an infection controls perspective. So for patients, next slide, please. For patients who are diagnosed with COVID-19, we think of criteria for removal from isolation or quarantine in terms of when we can consider them no longer infectious to others, either in the community or the healthcare setting. And I'm going to give an example of sort of two spheres of strategies we've seen used and been using also here at Penn that are currently proposed by the Centers for Disease Control, which I've listed in this table on the left. And this involves either a time and symptom-based strategy or a test-based strategy. So as an example, the CDC proposes that to clear patients by a time and symptom-based strategy, they are required to be afebrile for at least 3 days with improving symptoms and at least 10 days from symptom onset. For patients being cleared by a test-based strategy, they require clinical improvement and then the results of 2 negative SARS-CoV-2 RNA molecular tests from respiratory specimens that are at least 24 hours apart. And they do give the caveat that we should especially consider immune-compromised patient populations, mainly due to our concern that they'll remain infectious for longer than 10 days. And this sort of depends on whether a test-based strategy is feasible or desired by individual institutions. And so the choice between strategies for clearance from isolation and quarantine has really created a lot of differences in how institutions are making these decisions and how healthcare systems are navigating clearing patients. And this includes special consideration for immune-compromised patients such as transplant recipients, as well as other unique populations. For example, inpatients with prolonged hospitalizations where you may be thinking about de-escalating isolation precautions, or patients who interface with other congregate settings like a skilled nursing facility. And from discussions that I've had with many infection control departments across the United States, there really is a large variation in how immunocompromised populations with COVID-19 are being cleared from isolation and deemed non-infectious. And most centers have either used a more prolonged time and symptom-based strategy for transplant patients, even as far as 28 or even 6 weeks from symptom onset, or a test-based clearance strategy. And because in transplant patients we have concern about potentially more prolonged infectivity, it is tempting to think about a test-based strategy to try to give a more objective measure for isolation decisions. Next slide, please. But as has been mentioned by other speakers, I do want to discuss briefly some of the challenges with using a molecular test-based strategy for clearance from isolation or quarantine. And the first is that has been already discussed is that we really don't know the clinical significance of prolonged viral shedding from the respiratory tract in terms of is this actually viable infectious virus or just genetic material from old and dead virus. And there really is limited data available on duration of infectivity from studies looking at actual viral culture of respiratory specimens. And we have seen very prolonged shedding from nasopharyngeal and sputum samples relative to actual detection of viral genetic material through our molecular assays. But what this means in terms of infectivity is unclear, especially as these are often very low levels of viral detection many weeks or days from symptom onset. And just to give this in a visual representation, the figure on the right side of this slide is an example from a randomized control trial of remdesivir in over 200 patients in a study recently published in The Lancet. And my point here is not relative to the remdesivir effect, but just to visualize the prolonged viral shedding in upper and lower respiratory specimens of these patients. About 20% of them were still positive at 28 days from infection onset. And so we just have to think, if we use a test-based clearance strategy, we have to interpret the results of what is a very analytically sensitive viral RNA molecular assay, when really in the clinical setting, we're given a positive or a negative result without quantitative information of viral load and really no assessment of direct infectivity. Just to mention a few other challenges with the test-based strategy, there can be discrepancies between positive and negative results of upper and lower respiratory specimens, such as a tracheal aspirate versus a nasopharyngeal swab. And the actual logistics of using a test-based strategy, meaning 2 additional tests to clear patients, requires a lot of care coordination for outpatients. They have to have access to testing sites, and even things like swabbing technique at testing sites can impact results. And finally, this weighs into how health systems are flagging patients in their electronic medical record as infectious and needing isolation precautions. And it really creates challenges if there's variation in clearance policies for certain populations, such as immune compromised patients, which may very well be appropriate. Next slide. And so just to wrap up, I wanted to just mention how I think we should be thinking about our clearance strategies to best protect transplant patients and our care teams. The goal of our clearance strategy should really be to optimize safety of all staff and patients in the transplant healthcare setting and minimize any risk of exposure while patients are still possibly infected. And as I noted, the challenge is really to understand how this prolonged low-level viral shedding should impact our assessment of infectivity and medical decision-making in these patients. And at least here at Penn, we've already seen significant challenges in trying to manage transplant patients with COVID remotely to avoid exposures, for example, just due to limitations in telehealth and even lab draw access. And I think identifying how and when to bring these patients back into the healthcare setting safely is really essential. Monitoring prolonged viral shedding through test-based clearance strategy also can impact other medical decision-making in these patients, such as immunosuppression management, and also really creates judgment, at least from an infection control perspective, about how we safely perform future procedures in these populations, ensuring appropriate PPE, for example, if a patient later needs a bronchoscopy or a biopsy. And we've seen varying practices between healthcare systems, which have also created confusion as patients are hospitalized not at their home transplant center and then come back for appointments, where clearance strategies might differ. And finally, whichever strategy is used, the impact of how we clear patients from infectivity is going to impact management decisions for patients recovering from COVID who are either awaiting organ transplant or being evaluated as living donors.
Okay, thank you. We can now move on to the last presentation of this session. Please, Paolo, you can start your presentation.
Yes, thank you, Luciano. Thank you for this invitation to share this challenging title that have been assigned. So I was really stuck to the indication. So I have 3 slides, so I will be very quick. So we will recover some time. And the next slide, please. So critical patient with the 2019 coronavirus disease, even those with nucleic acid test results turn negative, and those receiving maximal medical support have been noted to progress to irreversible fatal respiratory failure. And lung transplantation as the sole therapy for end-stage pulmonary fibrosis related to acute respiratory distress syndrome has been considered as the ultimate rescue therapy for these patients. Next slide. Next. So, lung transplantation as therapeutic option in acute respiratory distress syndrome for COVID-19 related pulmonary fibrosis has been reported so far by the Chinese colleague in 3 patients, where 3 male patients were urgently assessed and listed for transplantation, and 2 of the 3 recipients survived post-lung transplantation and started participating in a rehabilitation program. And the conclusion of this paper is that lung transplantation can be performed in end-stage patients with respiratory failure due to COVID-19 related pulmonary fibrosis, and if confirmed positive or third negative virology status without organ dysfunction, lung transplantation provided the final option for this patient to avoid certain death with proper protection of transplant surgeons and medical staff. Next slide. So, and I would like to share with you a challenging case that we have to face over the last weeks in Italy. This was an 18-year-old male admitted on March 6 because of 7 days of fever, cough, and progressive dyspnea. And but 2 days after admission, he was intubated and mechanically ventilated because of worsening dyspnea despite a CPAP, non-invasive ventilation. He was treated with lopinavir, ritonavir, and an anti-IL-1 monoclonal antibody and some broad-spectrum antibiotics. But despite the mechanical ventilation, he needed to be put on venous ECMO because of lack of response to mechanical ventilation. And this guy was impossible to be weaned from ECMO because of severe irreversible lung damage. So they performed lung biopsy. There was a really terrible damage with thrombosis and necrosis of the whole lungs. So we discussed with the surgeon who were considered to list this patient, and with the National Center of Transplantation and all the committee of the National Transplant Network on what to do. And eventually we decided to list this patient, so he was listed on April 28th, and is still on the waiting list because no lung has been available so far. That was good for him. And but we decided based on these findings, so that the recipient had 2 negative BAL samples, negative nasopharyngeal swabs, negative pleural effusion with a very low viral load by Pcr. He had negative plasma in all the samples that have been collected, negative rectal swab, negative stools, but on 21 of April, he had a low level of viral load by PCR. So we decided to do a viral culture to see if this was really infective virus or was just some RNA that was amplified by PCR. And viral culture in the BIL and the pleural effusion came back to be negative. So based on the result, thinking that it cleared the infection, and the main problem of this very young guy was the lung damage, and so the lung transplantation was the only option that could be offered to him. So we decided to list this patient. And yesterday I have been called by another center with a very similar case, and we are considering, we didn't finalize the decision to list this patient, but we are considering to list another patient. So one of the problems that we are facing now is what to do with this patient without any comorbidity, with severe lung damage, and where the organ transplantation is the only option to offer them a survival opportunity. And so I think this is something that we are going to face in the near future, and we should consider what is the best option to offer. In the same time, I've been called by another center with two patients with an active SARS-CoV-2 infection and acute liver failure with fulminant hepatitis, probably due to a tocilizumab treatment, but because of the ongoing infection, so I was not willing to allow liver transplantation in this patient. So, but this is really a challenging situation. We have no clear-cut answer. We have these 3 cases transplanted in China, and to the best of my knowledge, there are no other experience but this one that we are going to perform in Italy right now. So that's it, and thank you for your attention.
Thank you, Paolo. Thank you very much to all the speakers, and in particular to Dr. Zhu, who is speaking in the middle of the night. And now, unfortunately, we don't have time for discussion or question because we are running a little bit late. And then I will be glad to move to the next session.
Hi, I'm Lou Tepperman, Director of Transplantation at Northwell Health. And this last section is what have we learned and how we will prepare for the next wave. And I want to thank you all for staying. Our first presenter is Fernanda Silveira. She's the Associate Professor of Medicine, University of Pittsburgh, and she will address what to do when the donor history is positive for COVID. Thank you. Fernanda?
Sure. Thank you very much for having me here this afternoon. Next. When I prepared to talk to you today, the way that I decided to approach this is by dividing these donors with a history of COVID-19 into subgroups based on PCR results. And I purposefully decided not to include any serology data. As has been mentioned already, this data right now is very murky, and I think it would be very difficult to know how to interpret. So thinking about PCR, these donors can be divided into those with a positive PCR at the time of donation and those with a negative PCR at the time of donation. And first, I will talk about the ones with a positive PCR, because these are the ones that are most straightforward. And for these donors, we have to consider not only the quality of the organs, but there are also some very other important considerations, with one being the possibility of donor-derived infection, which has not been described up until this point, but it's certainly possible. But not only that, but we need to worry about the risk of transmission to the recovery teams, to the healthcare personnel, and in the hospital. And for a disease that at this moment we have no prophylaxis or treatment. So for these donors with a positive PCR, at least at this point, they should not be utilized. Next. This audience knows that COVID-19 is a viral pneumonia, so the lungs are the primary site affected, but we have growing evidence that in reality it is a systemic disease. Those patients, particularly the ones with moderate to severe disease, they have evidence of liver injury, acute kidney injury, and cardiac dysfunction. And even though it seems that the involvement of these organs is perhaps primarily due to the robust inflammatory response, we cannot say with certainty that in at least some of the cases there is no direct viral effect. We know that viral RNA can be found in the blood of symptomatic and pre-symptomatic patients, and autopsy data has shown the presence of viral RNA or viral particles in the liver, kidney, and heart, suggesting that there may be some direct effect from the virus in these organs. And there is a lot that we don't know, especially if what are the long-term sequelae of COVID-19. And one of the most feared sequelae that we face is the post-infectious pulmonary fibrosis, as in the case that Paulo just mentioned. But we also don't know if for those patients who do not have any laboratory abnormalities or evidence of organ dysfunction, if we can safely rule out organ involvement. Next. So for those patients with a negative PCR at the time of donation, the quality of the graft will probably depend on the degree of organ dysfunction that was suffered during the episode of COVID-19. And certainly those patients who have more severe disease, especially those who require mechanical ventilation, perhaps they're not going to be good lung donors. But another thing also to consider is the time from illness. And I think the time from illness will be important for two reasons. One, it has been mentioned before, viral shedding can be prolonged. We don't know if this detection of viral RNA will represent infectivity or not. Or more yet, we don't know what is the presence of virus and infectious virus in donated organs. And the longer time you have from COVID-19, that will increase the probability of no infectivity and transmission to the recipient and the healthcare personnel. But not only that, but the longer time has passed from disease, that will allow you to better evaluate any potential consequence of the infection to the transplanted organ. So when we look at different organs, lungs and hearts are probably the ones that will carry the highest risk. We know that there is better evidence of direct effects in the organs. In the case of lungs, that is the primary site of infection. But one should think that if you have a donor with a negative PCR who has a normal ABG, has a normal CT scan of the chest without any evidence of pulmonary fibrosis, perhaps there could be a lung donor. And for hearts, if that donor has a normal EKG and a normal echocardiogram, that donor can perhaps be a good heart donor. In the case of liver and kidneys, it's probably okay to utilize these organs since we have fewer concerns about long-term sequelae and also of direct viral effects in these organs. As of now, the use of these donors has not been reported, and as more and more of these donors become available and they are utilized, it's going to be very important to monitor graft and patient survival and adjust our decisions based on this data. And currently, in the absence of enough donors available, perhaps the biggest risk that we face is to not use donors that are suitable and have a negative PCR just because of a previous history of COVID-19. Thank you.
Our last presenter is Melissa Greenwald. She's the Associate Medical Director, the Donor Alliance in Denver, Colorado, and she has been heavily involved in government and representing the transplant community. She will address what standards should be used for the donor testing going forward.
Hi, thank you very much, Lou. Next slide. So I'll start my presentation updating you on the current situation with testing under Emergency Use Authorization. Dr. Gable did actually speak about that earlier, but hopefully this will give you a little insight in the process to understand the limitations of test results at the current time. All SARS-CoV-2 assays currently in use in the United States are being performed under Emergency Use Authorization, or an EUA. This EUA is a mechanism that allows the use of investigational assays that have not been reviewed by FDA to be used during a public health emergency. But it is important to keep in mind that while all assays under the EUA have been somewhat evaluated for their validity of the test results, They certainly have not been fully evaluated in the manner required even for doing using investigational assays under, say, an IND or an IDE, and certainly not like for licensed or approved assays. Of course, some of the reliability of these assay results is being weighed against the need to have available assays to provide information for clinical care and for assessing the impact of SARS-CoV-2 on the community. And FDA has provided a fair amount of guidance on that. To give you an idea of numbers, under EUA, there are about 60 test kit manufacturers or commercial labs listed with diagnostic assays, and 25 high complexity molecular based laboratory developed tests. But really the antibody assays under EUA are not listed on the website, even because as has already been mentioned, they've not really been reviewed at all by FDA yet. Next slide. But next I'm going to talk about how we're testing donors. And at Donor Alliance in Denver, since about mid-March, all the donors have been receiving nasal swab with a PCR assay. Those donors must test negative for SARS-CoV-2 to donate, and before they get moved to the donor center. So to date, no donors that we have tested positive, and one potential donor was declined to proceed because of clinical concern for COVID despite a negative test result. And also to put the situation in context as far as donation that's been happening, our average monthly donation rate is 17 donors with 50 organs transplanted per month. And in March, there were 17 donors as well as 45 organs transplanted. In April, we had 12 donors with 33 organs. And then while we slowed down a bit on donations between mid-March and through the end of April, from our typical, things are starting to pick up again. There are assays available at DRL, which does solely donor testing. They have both a Becton-Dixon and a Bio-Rad SARS-CoV-2 assay, both using RT-PCR technology on nasopharyngeal or oropharyngeal swabs. And the stat turnaround time for organ donation for those is about 6 to 8 hours. There are IgG and IgM assays with this. I just wanted to mention that gold standard is the name of the assay, and not saying that IgG and IgM testing is in fact a gold standard. I think we've all discussed enough that we don't really understand what that means. But certainly that organ donor testing is a separate supply chain, and it's not taking away from your ability to do testing of COVID patients. And right now, the capacity for donor testing is about 300 donors per month, and that's going to be trending upwards more towards 5,000 donations a month that could be tested. So next slide. Of course, I was asked to comment on the standards for testing moving forward. And that was what I spent a large part of my career in government doing. And this list of research to inform future testing policy is really the information that's going to be needed in order to make rational policy decisions on how to address a donor testing strategy. And frankly, we just don't know enough to develop one at this point. We certainly need to understand assay performance characteristics and have those assays fully validated. Moving into the future, we don't know how often the virus travels through the blood system as opposed to the lymphatic system, and if in fact there is a viremia, how long that lasts. There's been some data showing some viremia, but we really don't understand how often that's occurring. We need to know about the tissue tropism, as the last speaker covered very nicely. And of course, the transmissibility via organs or blood. The length of viral shedding would be helpful to understand. Does the RNA positivity on swab samples accurately measure infectivity? We don't know. And of course, the $1 million question is going to be whether antibody prevents reinfection or transmission. So everyone across the world is working diligently to learn the answers to all these questions. So I will stop here and thank everybody for your time.
Thank you, Melissa. As the hour or hour and a half is late, any questions that we haven't gotten to will be posted to the COVID FAQ sheets for the different society partners. We'd like to thank all the societies for sponsoring this: AST, ASDS, AOPA, CST, ESOT, ISHLT, NATCO, TTS, and UNOS. And this webinar will be available on everyone's website and YouTube within 24 hours. And a special thanks to Emily Bloomberg for her foresight and innovation to helping make these presentations possible. We would like your feedback. It's highly important and encouraged. Let us know if these webinars have been helpful to you and if the format suits you, and any other COVID topics that you're interested in. And thank you very much for joining.